Hi, my name is Kelsey Gaid. I'm a physician assistant with the University of Utah Health in Salt Lake City, Utah, primarily focused on hepatology for about the last 10 years. And today we're going to talk about fibrosis, not steatosis, as the true prognostic driver for MASLD and MASH. And I have here with me Andrew Garza.
Hey there. Yeah. So I'm Andrew Garza. I'm a physician assistant practicing in outpatient adult endocrinology in Grand Prairie, Texas, a suburb of the Dallas-Fort Worth area. Super excited to be here to talk about my experience with MASH, specifically MASH with fibrosis from the endocrinology perspective.
Awesome. All right. Well, let's start with talking about the difference between just general MASLD versus MASH. So what do you typically see in your patients who have concerns about just steatosis or potentially having fibrosis as well?
So I think, a lot of my patient concern is primarily just driven from what we see on baseline labs. And for many years, patients have wondered, they'll walk into an office visit, how do my liver enzymes look? How does my liver look? And I think, it's important to take a pause and recognize the limitations to just using some basic screening tools, including a FIB4, right? So I have a FibroScan in practice, and we're fortunate to have one. So that's shed a lot of light on the conversation in terms of steatosis versus fibrosis and how my patients can actually relate to some of those results. So that said, I usually have them navigate the conversation by saying, hey, look, there's two different things that we're looking at with this FibroScan specifically. We're looking at the fat content within the liver, getting a quantitative metric of that. But we're also taking a look to see if there's any evidence of this liver scarring is kind of how I break it down for these patients. And Kelsey, you and I both know, and many of our audience members here, that fibrosis specifically is the most important factor in terms of liver-related mortality and all-cause mortality. So it's very important that we drive that point home, that fibrosis is really what we're primarily concerned with.
Right. Absolutely. I agree. I think many of our patients are very concerned about the steatosis, which is still a risk factor. But that fibrosis is really that driving factor for prognosis and need for potential liver transplant. Other risks, including hepatocellular carcinoma at those advanced stages, F3 and F4, as well as decompensations and other complications down the road. So really that fibrosis stage is super important and important for patients to understand that as well.
Yeah. At the community level and the patient level, they've heard, fatty liver for many years and have probably been informally diagnosed with that over time, and maybe even a little bit more formally with just regular transabdominal ultrasounds and things like that. And by the way, just as a side note, if you have someone that just has a regular transabdominal ultrasound and it shows fatty liver, that's a little bit different than seeing fatty liver on something like a MRE or MRI PDFF and a FibroScan. It's usually there's substantially more fat deposits if you see it on just a regular liver ultrasound. But that aside, they've been diagnosed with this fatty liver, and that's what they're really hanging on to. So education at the community level to let patients know, hey, this fibrosis is really what drives some of this progression risk, I think is really big, and that education's key. Many studies show that fibrosis is an independent risk factor for this progression outside of inflammation, outside of ballooning and other signs of steatosis.
Yeah, absolutely. And that brings up a good point too with the ballooning stuff that we notice on liver biopsies. You could have two patients that have very similar NAFLD activity scores on biopsy, just the way that we score, but one could have that higher fibrosis risk factor compared to another that may just have that really high steatosis and no fibrosis. But that NAS score could be equivalent, but one is really going to have that higher risk factor for progression. And I think that also brings up one of the things that we're looking at for treatments now is our endpoints to look at MASH resolution without worsening fibrosis, as well as that improvement of fibrosis without worsening of MASH activity. So looking at that as endpoints as opposed to, just monitoring that NAFLD activity score on biopsy.
Yeah, exactly right. And I think the FDA finally, came to the conclusion that, hey, we need to look at this fibrosis specifically, right? And as we've talked about previously, there's that major risk for progression to cirrhosis and hepatocellular carcinoma, specifically for these patients with fibrosis, that F3 and certainly, even some instances F2 stage. So making sure that we're following that fibrosis as a prognostic factor is huge, certainly.
Absolutely. Well, let's talk a little bit about weight loss and reaching that 10% weight loss threshold typically is what we want for our patients to start that reversal of fibrosis and, reducing risk of progression of disease. So from your standpoint in the endocrine subspecialty, what is your approach to this?
Yeah, absolutely. So I think there's several limitations at the community level for the exercise and diet routes for for physiologic weight loss, just without pharmacotherapy, and there can be limitations in the sense of socioeconomic factors and the challenges of reading a nutrition label, and just generally speaking, people who are just kind of busy, and it's relatively challenging to eat healthy. It requires a little bit of time and energy and effort. Fortunately, we've had a lot of great pharmacotherapeutic interventions that have come to light within the last decade or so that now have increasing, relatively speaking, affordability and access, and a lot of cool secondary indications as well. So a lot of times we do use these medications, specifically the GLP-1 class of medications, as an adjunct to diet and exercise, whatever capacity that looks like for patients, to help achieve that weight loss. In my practice, I think with these GLP-1 medications, a 10% weight loss is more than achievable, but there are still limitations to that as well. Adherence due to side effects, adherence due to cost. And if you remember over the course of the last 2 or 3 years at various times, supply issues as well.
Right.
So seeing this weight loss at 10% as a magic bullet, so to speak, is sometimes not necessarily true in the GLP-1 or pharmacotherapy world. But I think it's a very attainable weight loss goal with GLP-1s if we can get them and tolerate them at certain dosages. What do you guys see in the GI hepatology space, Kelsey?
Yeah, I agree. I think initially there was a lot of hesitancy for providers in the GI hepatology space to prescribe these medicines because many of us are not trained in, using them, the side effects, all those sorts of things, and monitoring. I think in the past year or two, we've had more and more education because fatty liver, MASLD and MASH are kind of the driving diseases in the liver world now. So we're getting more and more comfortable using them. I think my general approach, especially on first visit with a patient, is just really understand like, what is your diet? What are you doing for exercise? Are you doing anything? And really kind of diving into those details. And then letting patients know like, hey, we want to help you lose this weight. We haven't had a lot of these options in the past several years, but now we have a lot of newer availability of things that insurances are covering because they understand the risks of these diseases, not just for the liver, but cardio, renal, all those sorts of things as well. So yeah, typically I'm harping on diet, exercise first, and then adding in additional medications, really making sure that they understand you have to make some of these changes in order for that medication to give you the most benefit in the long run, as well as help to reduce medication side effects as well.
Yeah. No, absolutely. I think you bring up a really good point there that all these medications are intended to be an adjunct to diet and exercise, right? So we really want to provide counseling to make sure that patients are doing their part to the capacity that they feasibly can. But these medications can serve as, an additive to really help kind of push across the finish line. And to your point, there's a lot of really cool secondary indications, which in the endocrinology space, I'm very fortunate for. Several years ago, I might not have had patients that were referred to me by renal or hepatology for diabetes management that were already on a GLP-1 at baseline. But now that, patients have through various different trials, secondary indications, other subspecialties are getting increasingly more comfortable with prescribing and managing side effects, I think it's a really neat time period where we can truly co-manage patients to the best of our abilities as healthcare providers.
Yeah, I agree. Do you see a lot of patients with bariatric surgery at all going that route in your practice?
I do see a handful. That's something that generally GI Hep is going to manage and take care of, and primary care will refer for. So I'd be really interested to know what your thoughts are on resolution and improvement, resolution of MASH and improvement of fibrosis in these bariatric surgery patients, and if you've noticed any particular surgeries that are more impactful for fibrosis improvement.
Yeah, I would say it probably depends on the patient. As many of the patients that get bariatric surgery, whether that be like a Roux-en-Y or a gastric sleeve, can obtain that more than 10% weight loss and maintaining that as well. I would say Roux-en-Y are some of the more drastic weight loss surgeries, may achieve more of a 25% loss overall for weight loss, which is great. There are still situations that I've seen patients coming to me now that have had bariatric surgeries in the past, and now they're still showing changes of steatosis and fibrosis. So that's kind of a newer thing for me to try to figure that out. But a lot of times it is that the patients have lost the weight, and then, maybe 5-10 years down the road, they start to gain that weight back. And I think that's where that return of steatosis and fibrosis can happen when they get that weight regain several years after.
Yeah, I think you bring up a really interesting point. So if I can draw the parallel to the endocrinology space specifically, like I mentioned, we have a FibroScan in office, so we're able to screen patients that meet criteria for screening. And it's really interesting is that there are patients who have been on GLP-1s at whatever the max tolerated dosage may be for that specific medication that we're still diagnosing with fibrosis, or we're still diagnosing with steatosis as well. So I think it's important to discuss the potential for dual therapy or alternative medications outside of weight loss, when either weight loss alone doesn't have complete fibrosis regression, or potentially there's still some residual steatosis as well. So that brings us to Resmetirom, and I want to know, Kelsey, what that looks like in terms of utilization, and talk a little bit too about the mechanism of action, if you can, and where it fits in your therapy progression.
Yeah, of course. I think Resmetirom has been a great addition to help these patients that are not able to sustain that 10% threshold, or are having return of some of that weight gain after several years. So Resmetirom is a selective thyroid hormone receptor-β agonist. So thyroid hormone receptor-β agonist, thyroid hormone receptor beta is highly expressed in the liver. The alpha drives more of the cardiac systemic effects, whereas the beta is more so targeted in the liver. Basically, we can see it with MASH, or fatty liver disease, MASLD type stuff. We see impaired thyroid beta signaling, as well as mitochondrial dysfunction and lipid buildup. So this medication, Resmetirom, is increasing that mitochondrial fat oxidation in the hepatocytes, decreasing that lipogenesis to help reduce that inflammation and progression of fibrosis. So really is beneficial to add on for a lot of these patients.
It's a blast from the past. You got me thinking about the Krebs cycle from undergrad, and I thought that I would never need it again, but here we are, right? But it's such a cool therapy, right? Like, to be able to use this. And in my practice, like I mentioned, I have patients that are on GLP-1 therapy that have reached this 10% weight loss threshold. And to my knowledge, usually that 10% weight loss threshold is the goal, but about 50% of patients achieve that fibrosis improvement by one score with that. So implying that there's a lot of patients who won't necessarily be able to achieve fibrosis regression by a staging or two as a result of that weight loss alone. So I do have many patients that are on dual therapy with GLP-1 and Resmetirom. I think it's important to also recognize that in the Maestro-NASH trial, GLP-1 usage was not necessarily an exclusionary criteria. Now, sub-analysis of these patients that were on GLP-1s in terms of dosing and therapy of duration impact in that trial is not necessarily a sub-analysis that is released yet to the public for data. But I think it's important to recognize that there can be dual usage of these medications. And in my practice, I have a lot of patients that are on both.
Yeah, I agree. I think, I had a patient I saw today that was asking, well, when can I stop Rezdiffra? And I'm like, well, you know what? I don't think that is something that we should be considering right now, as we are seeing some really significant benefits, that improvement of liver enzymes. We're, at a year reassessing for that fibrosis and noticing many patients are having that improvement of fibrosis. And I know we have two dosing, regimens that we use dependent on patients' weight. But both of those, about over 25% of patients achieved that fibrosis improvement. And that's pretty significant when we didn't have any medications previously to help with this disease.
And for newer prescribers, what Kelsey's alluding to with the dosing is a weight-based dose. If you're over 100 kilograms, you will use the 100 milligram dose. If it's less than 100 kilos for the patient, use the 80 milligram dose. And if you have someone who is on certain medications, the one that comes to mind is Plavix specifically, then you drop them by a dosing. So you may use 60 or 80 in those particular patients. But Kelsey, you bring up an interesting point about the improvement over time. When do you generally repeat an assessment for fibrosis? And in your mind, is lack of progression still a treatment win as well? Or do you truly want to see regression to consider it a treatment efficacy?
Yeah, so generally with our liver guidelines, it was suggested to reassess a FibroScan or whichever, if you did MRE or something like that at 1 year. And as long as you did not have fibrosis progression, we are still continuing it. So that's kind of the main driver there. So whether you have improvement of fibrosis without worsening, or you have that MASH resolution. So really seeing those liver enzyme improvements as well.
Yeah, absolutely. And that's exactly the protocol that we follow in outpatient endocrinology as well. Well, Kelsey, this has been awesome. And I want to thank all of our viewers for listening. And if you have any more questions or have a desire for more information, certainly go to the MAP website, and there will be plenty more videos just like this one where you can improve knowledge base and hopefully have some questions answered. Thank you, guys.
Thank you.